Awesome. Awesome.
So how many recruits were playing?
20 some. Really close to 22. Yeah, it was a good show.
Everybody tell Savannah hi.
Hi, Sam.
She was apparently death warmed over from what she told me. Voice coming back?
Not really.
I'll take that as a no. Yeah, Thursday she did not look good and she said, yeah, I continue to feel worse. So, yeah. JV, I heard took second. Varsity, from what I was told, didn't play as well as they wanted to. But JV is apparently did well. Savannah, if you can hear me, just nod your head. Okay, you can hear me good. All right. And I'm just gonna try. Okay. Okay, does that work? All right, that works. Okay, thank you. All right. So okay. And then, right. That works, yeah. Okay, good. Okay. All right, I think we're back in the saddle here. Very good. So, well, we're all here. Let me just remind you. Fall break is this week, so there's no lab this week. So Thursday, sleep in, take a look out. Go to the gym. Very parents, you love them, you know, all that good stuff.
Are we gonna have a quiz on Monday?
Do you really want one?
No.
You really want one? I didn't schedule one, but if you really want one, we can have one. Did you get hit by Jimmy Dennis ball?
Maybe.
Maybe, okay. So, went well?
Yeah, it would go really well.
Okay,
We're supposed to find out, living in this week.
okay, excellent, excellent. Let us know how that goes. And, usually when, schools get to the interview process, you have to give them, a good reason. So they have this pool, and they're trying to give them a reason why they should think that you're towards the top of that pool. And then they usually start giving offers to people, and then as those people reject offers, and then start giving offers to the next group. So, if you're anywhere usually within the first 3 quintiles, usually the chances of getting it are quite good. So, we'll just keep our fingers crossed. So I hope you guys all read the announcement about Dr. Baldwin. It does not look like he had a stroke. There's no evidence that neurologist said there's no evidence of a stroke. he's been imaged 3 times. You can't find any evidence that you had a stroke. You don't have any neurological deficit that would suggest you had a stroke. You don't need the rehab, therefore, that comes with a stroke. So we're going to call it not a stroke, which Bruce then asked, well, then what happened? And they said, we think you had a migraine headache. Now, it turns out migraines run in his family. And it turns out his sister has migraines that have symptoms similar to what Bruce had. So, which I asked him, you've had migraines before? He said, I always thought they were sinus headaches. It turns out they might very well have been migraines. So, Bruce, hopefully the word is he's going to be home today from the hospital. And I wasn't able to see him yesterday, but I chatted with him on the phone. It was Friday, I saw him Saturday. Boy, I didn't see Friday and Saturday. Huge. And then talking to him yesterday, he was his old self telling really horrible jokes that really weren't that funny. And mumbling in Japanese and yeah, all the stuff that we know and love from Dr. Baldwin, or maybe don't love quite so much, but tolerate. So yeah, Bruce will be his own hungry self. Again, it'd be nice, I think, for him to be back in a familiar place, because if any of you have had the misfortune of being in a hospital, well, you with your surgery, you'll understand that hospitals are kind of dreary places, and trying to sleep in a hospital is, you know, if you're just taking mallet and put me in another day, you can not sleep. And stroke protocol, they have to wake you up every hour. So you don't really, yeah, make sure you don't fall into a coma.
Why would you call them? Can you just explain how you would call them?
Because the area of the brain that's damaged may tend to shut the other parts off. And it's not the same, but when you have a heart attack, the scarred area can start to shut down the area near it. That's called hibernating myocardium. You talk about that all in your cardiac course? Oh, okay. Luke, anyone here had? Okay. When do HS majors take the cardiac course? Junior, senior? Okay. Usually, you're a junior, so you haven't had it yet. Okay. Have you had it? Same situation. Same situation, okay. So mechanismically, it's very different, but that sort of thing can happen, and so the brain now parts of it just start to shut down, and so people can fall into a coma. And by waking you up, it ensures activity and it ensures normal activity, so that the brain starts to rewire around the dead areas. That's the other reason why they wake you up. It's also to make sure that you don't have a second clot or bleed. Because if you wake up, you know, and your eyes are crossed or something like that, then they know, you know, something is amiss in Tinseltown. So that's why they wake you up. So if you're tired and you can't sleep because if you get out of here. So I asked Bruce, I said, because he got moved from ICU yesterday, I said, you sleep any better? He said, not really. I'm not really one for hospital. I said, well, who is? I'm thinking the doctors and nurses are one for hospitals. So, and I don't know if they just gave you lots of great pain meds and you just, or if.
I woke up and I was like, for like 2 minutes, and then I was out there. You know, I was chilling.
Oh, yours was an outpatient procedure.
Yeah, I went to the aggressive surgery center and just put it. It was done. Left immediately.
They didn't keep you for observation.
No.
Okay. They just sent you home with heparin that you're supposed to inject, and
Yeah, I think that, I mean, they kept me probably for like 30 minutes just to make sure I wasn't feeling too sick.
right, you didn't have a clot or something.
Yeah.
You didn't have PE or something like that. Okay.
Wait, so it can happen that a migraine prepare your sleep.
Yes. Yeah. People with severe migraines, they get trouble talking, and their vision can just disappear. So you can get cranial nerve palsies with severe migraines.
So what happens in the brain during a migraine? Like what?
So there is the latest theory is called the cortical wave theory, where you have a center it's usually serotonergic neurons, and that's why serotonergic drugs seem to be efficacious against migraines. You get this activity essentially that gets amplified to different areas of the brain, and one of the targets is this calcitonin gene related protein, CGRP. And CGRP levels go way up during a migraine, and CGRP seems to be a mediator of pain. So serotonin causes vessels within the brain to expand. That puts pressure on the meningeal nerves. And then the CGRP seems to cause the ringing and what have you, and it's a positive feedback sort of thing, and it usually starts, usually say here, and it tends to wrap, that the activity tends to wrap like that. That's why blocking serotonin or blocking, so the triptans actually block serotonin signaling in the brain. And then the CGRP related drugs, there's that, Serena Williams is on that commercial for that new powdered CGRP inhibitor. That CGRP inhibitors only have to, you have to take them to prevent migraines. These you can take, powdered ones you take during the migraine. To cut off the migraine that's already active. So those drugs unfortunately are quite expensive. You don't usually take them unless insurance pays for them. But that's usually the case with the migraine. And some people get auras. I had a student one year, this was a long time ago now. She sat right there. And she get migraine, literally she'd zone out. Her eyes would glaze over. And she'd just sit there as though, and then be Heather. And it was clear she wasn't writing anything down, she was just sitting there, and she had intractable migraine. You know the trainer, David, yeah, his wife has intractable migraines, and she had to sit in a room with the lights off and no sound sometimes. And every time I talk to David, she tried this. Kind of worked. She tried this other medicine, I didn't work at all. So they're just trying different things and what have you. So that's an example of a person with really severe migraine. So yeah, they can cause cranial nerve type, stroke type symptoms. So yeah, good news for Bruce, good news for Spring Arbor. So yeah. So let's get into the autonomic nervous system. To review, yeah, we talked about how the sympathetic nervous system, the cell bodies of those nerves are in the spinal cord. That's the strangest looking spinal cord I've ever seen, but anyway. Those then exit, and then they are going to synapse typically in these paravertebral bodies. The nerves, so the departure from the DRG to the paravertebral bodies, those axons are myelinated. Those are called white rami immunocontates. Those are myelinated. The fibers then that exit from the paravertebral bodies, those are not myelinated. And those are called gray rami immunocontates, or WRCs and GRCs, which is a right bit less. Oh, you know what? I should have written those. Savannah, I'm sorry, you can't see the board. I'm terrible. I'm dirt. I'm awful. I'm sorry. I repent in sackcloth and ashes. Here, let me write those here so you can see them. They're
The white ones like good?
the white ones. So the okay, come on, focus. Focus. Oh, there. So white rami communicantes. Those go from the spinal cord, because remember the cell body of these neurons are in the spinal cord. They go to the paravertebral ganglion. Well, ganglia, they're connected. The so-called the sympathetic chain ganglia. So these travel with spinal nerves, but then they depart from the spinal nerves. That's white communicantes, white ray communicantes. From these, they go to their targets. And these fibers are called gray rami communicantes. And these are unmyelinated.
Okay, so when they depart from the spinal nerves and go to the target, they're the gray one.
They depart from the spinal nerve and go to the ganglia. That's white rami communicantes. And those will be myelinated usually. Because the spinal nerves coming from the spinal cord are usually myelinated.
Yeah.
Usually. These then, the gray rami communicantes are unmyelinated.
Mhm.
And so that is what is shown here. So those are your sympathetic chain ganglia. And as we said, your sympathetic nerves, because they're all connected the way they are, they tend to be activated as a unit. That's this principle of mass activation. Mass activation. And this simply shows you the different divisions of the spinal cord, where they go, and so on and so forth, their targets and blah, 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 what have you. And remember, the sympathetic nervous system goes from T1 to L2. T1 to L2. So that's why it's the thoracolumbar division of the autonomic nervous system. So the parasympathetic division is cranial nerves and sacral nerves. So S2 to S4, and then the cranial nerves in particular, 3, 7, 9, and 10. Cranial nerves 3, 7, 9, and 10. So these parasympathetic nerves, they exit the central nervous system. They're going to then synapse in certain ganglia. And it depends on the nerve as to which ganglia they will synapse with. But then those postganglionic nerves will go from that ganglion and will then innervate the target. And it's not uncommon for parasympathetic nerves, particularly the sacral nerves. They have very long preganglionic fibers that synapse in terminal ganglia. These terminal ganglia are found right on top of the target organ. So a good example would be the bladder. Would it help to close the door? Is that loud enough? Is that bothering you or no? Okay. Man, it's hard to write with a mouse. So when it comes to the bladder has a ganglion that's essentially right on top of the wall of the bladder. So your S3 nerves essentially are going to innervate that terminal ganglia that's essentially in the bladder. And then those nerves go from that terminal ganglia to the actual muscles of the bladder. Reproductive organs, ditto. And the same also for the lower part of the intestines. So parasympathetic nerves, the preganglionic nerves, whereas sympathetic preganglionic nerves will travel with spinal nerves. They will depart to go to the paravertebral bodies, but parasympathetic fibers don't travel with spinal nerves. And I think this is about the part where we left off on Friday, yes? Okay.
So as we said, 4 cranial nerves contain preganglionic parasympathetic nerve fibers, bless you. And they are 3, 7, 9, and 10, cranial nerves 3, 7, 9, and 10. So the first 3 of these, oculomotor, facial, and glossopharyngeal, they will emerge from nuclei in the brain. They're going to synapse then with various ganglia in the skull. From there, the postganglionic fibers will extend their axons and innervate their targets. So if we talk about the oculomotor nerve first, the oculomotor nuclei in particular, that's the Edinger-Westphal nuclei we talked about, that are right behind the motor nuclei when it comes to the oculomotor nuclei. They emerge from the midbrain. The preganglionic fibers synapse with neurons in the ciliary ganglia. The ciliary ganglia. And they are going to innervate the ciliary muscle and the constrictor. So they're involved with, yeah, it gets to you after a while, doesn't it?
After a while.
Yeah, after a while, it just, yeah. The ciliary ganglia will innervate both the constrictors and also the ciliary muscle, so it allows the ability to accommodate. And okay, I'm to really apologize now because, oh, blast it. I didn't. Nope, 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 nope. I didn't get out of that. Here it is. There, up. Okay, let's just do this. You, okay, you go away. No, I don't want to keep my scribbles there. All right, there. Yes, I'm glad to hear that. Okay, there. There's where I want to go. Now, the ciliary ganglia, just in case you don't remember from A&P, or maybe they didn't teach you this in A&P, I don't know. So this is your eyeball. Lens, okay, it's ugly. And that's the optic nerve. Yeah. You have, say that's the lateral rectus here. That'd be the medial rectus. So lateral rectus, medial rectus. The ciliary ganglia is right here. CG, Charles Grassley. That's the ciliary ganglia, and that's going to innervate essentially these muscles here. It's going to innervate this here, and then what have you. All right, so the parasympathetic input from the oculomotor nerve, those preganglionic fibers are going to innervate, are going to synapse here. And the postganglionic fibers come from that ciliary ganglia that's essentially right up against the optic nerve. Optic nerve. Okay, so they're behind the eye, essentially.
But the postganglia one's the one that are coming from the ciliary.
That extend from the ciliary ganglia and innervate their targets.
Okay.
Yeah. Facial ganglia, those are going to originate from the pons. They actually originate from the border between the pons and medulla, the so-called pontine medullary angle. They're going to travel to the pterygopalatine ganglion. And the pterygopalatine ganglion is pretty much, if you look at the
look essentially at the eye socket, it's pretty much in the floor, just below the floor of the eye socket. So if you stick your finger in there in that superior fissure you have there, right below that will be the pterygo
palatine ganglion. So if you go right below, so where that fissure is below there, that's going to be the location of the pterygopalatine ganglion. And then those postganglionic fibers are going to innervate the submandibular. The lacrimal glands, nasal mucosa, and pharynx. Another group of fibers are going to terminate in the submandibular gland. The submandibular gland is going to be essentially right in here. And that's going to go to the sublingual and submandibular salivary glands. The parotid, remember, is innervated by the glossopharyngeal. The other two, submandibular, sublingual. And when you guys go to the dentist and she tells you to stick your tongue out and then she takes her left finger and feels under your tongue. Okay, Emma knows what I'm talking about. The others of you are going, dentist, who's that? She's feeling for hard spots on the gland, because hard spots on the gland or bumps could be tumors. And most salivary gland tumors are caught by dentists. That's what she's looking for.
Will they touch your tongue when fishing?
No, they have you stick your tongue out, and then usually they'll wrap it in a wet, sterile tissue. They'll pick it up and then they'll look on either side for any bumps, and then they'll usually feel. They usually with a gloved hand just feel. For kids, they have flavored gloves and everything. It's really kind of cool. Oh yeah, they have grape, they have strawberry. Yeah. Sorry, my dentist doesn't use those, but the pediatric dentist, they use flavored gloves. Yeah, see. Oh, okay. Okay, and dentists also will tend to feel the neck, and again, the thyroid. They're not cupping a feel, they're looking at your thyroid to see if there's any hard spots or bumps or any on the thyroid. And then they'll feel here, they're feeling the parotid gland, they're looking for tumors. That's what they're doing. And they'll usually tell the hygienist, oral cancer screen negative, or maybe you found something or whatever. Okay. And if you haven't been to the dentist lately, you should go to the dentist. You go to the dentist at least once a year. If your dental insurance allows, twice a year to get a cleaning. If you don't get your teeth cleaned, your gums are going to recede. And when they recede, they don't come back. Or if you get too vigorous with a toothbrush, like in my case, your gums start to recede. Okay, that's the facial nerve. The otic ganglion will receive preganglionic fibers from the glossopharyngeal nuclei. And that's in the pons. And those are going to innervate the parotid salivary gland and the otic ganglia. In fact, I have a picture of that because that's the hardest one to explain. So here's the foraminal valley, and the foraminal valley is foraminal valley is this whole right there. So as it descends, essentially, it's right below the foraminal valley, as you can see here. So right there, that's your otic ganglia. And that otic ganglia will send their fibers to the parotid gland. And since the facial nerve essentially goes right through the parotid gland, that's why facial surgeries can put you at risk for paralysis of the face and so on and so forth. All right. Back to the slides. Now, the vagus nerve does not really synapse with any ganglia. It essentially does not pass go, does not collect $200, just go straight to the target organ. The vagus will be a part of several nerve nets that are over the esophagus, that are over the trachea. Those are the esophageal plexi, the brachial plexi, nerve plexi. It then directly will innervate the heart, and then also the stomach, and then most of the intestine, and so on and so forth. And so the vagus, as you can see, it's the nerve that wanders, and those postganglionic neurons are located within the innervated organ. So again, we see the anatomical theme with the parasympathetic nervous system, that the preganglionic fiber is quite long, the postganglionic fiber is quite short, which is just the opposite for the sympathetic nervous system, which is what I said here. And the same can be said for the sacral branches. So the S2 branch will largely go to the second 2/3 of the transverse colon, descending colon, sigmoid colon, and rectum. Its branches essentially do the digestive thing. The S3 branch goes to the bladder, and the S4 branch tends to go to the reproductive organs. Those synapse with terminal ganglia in the organ. That's not the case with the autonomic nervous system. The autonomic nervous system will virtually always synapse with ganglia on the way to the organ. Now, there's a caveat here in that the sympathetic nerves that innervate the GI tract, they pass through the paravertebral ganglia, and they synapse with 3 different ganglia. There is the use the blackboard, use the so they'll use the celiac ganglion. That's a celiac ganglion. So the celiac ganglion is for T4 to T9. Then there's the superior mesenteric ganglion, superior because it's on top. Superior mesenteric ganglion will handle some of the, it'll also handle some of the T4 to T9. Yeah, it'll handle some of the T4 to T9, but it also is going to handle mainly T11. Yeah, T11 to T12. But a few of these fibers also go through that ganglion. Then there's the inferior mesenteric ganglion. That's going to handle pretty much L1 through L2. So you're going to have something called the greater splunknic nerves. This is a hard word to say, splunknic nerves. The greater splunknic nerves go essentially to the celiac ganglion. Then you have the lesser splunknic nerves. those go to the superior mesenteric ganglia, and then they go to their targets and what have you. Keep in mind, guys, this is not hard and fast. Some of these will go here. This is pretty hard and fast, but these will share fibers from each other. So don't take a look at this and say, oh, this one only gets fibers from those levels, because this one can get some fibers from other levels. So please keep that in mind. Those are for autonomic, the sympathetic. So these postganglionic fibers go straight from here to their targets. Same thing here, targets. They don't innervate with terminal ganglia. Those are the ganglia that they innervate.
So in the parasympathetic, they go to terminal.
They will go in many cases to terminal ganglia. And then, right, innervate their target. And so the postganglionic fibers in that case are very short. Not so with the autonomic, the sympathetic nerves. They receive nerves from L1 and L2.
And then post-ganglionic, that go after the celiac ganglion, are those longer then? Because they don't have to innervate.
They're still pretty long in some cases. When you dissect a cadaver, you can look in the mesentery. You actually need to pull the intestines out and hold it up and look at it. You'll see a dark spot, and that dark spot is that ganglia. You can feel it, it's bumpy. Most mesentery is pretty smooth. This is bumpy. And it's not a lymph node. Lymph nodes, when you squeeze them, they go squish. These, when you squeeze them, they're solid. Plus, the lymph nodes tend to be towards the back. This tends to be more towards the middle of the mesentery. Okay, TMI perhaps, but yeah, that's what they look like. Here's another table from your book that shows you the origin and the destination of some of these parasympathetic nerves. Please take a look at that table. Make sure that you have some idea where these come from. So functionally speaking, the autonomic nervous system is associated with the fight or flight response. One of the things that the sympathetic nervous system mediates is the release of epinephrine and norepinephrine from the adrenal medulla. Those two, I guess in this case, they're hormones, even though they're also neurotransmitters. They cause your heart to beat faster, and they do lots of things that mediate functions of the sympathetic nervous system. So by virtue of its mass activation, the sympathetic nervous system prepares the body for physical activity, particularly during emergency. So the heart rate increases, blood pressure rises, and blood gets diverted to skeletal muscles. So if we have, for example, a defender on a soccer field and a ball's coming towards them and the ball's going away from them, they have to get to that ball very quickly. And they have a burst of speed that gets them to that ball. They run far faster than they thought they could. That's an example of sympathetic input. The parasympathetic nervous system does not undergo mass activation. And it is associated with the rest and digest. The rest and digest activity. So the parasympathetic input to the heart will slow it down. Parasympathetic input to blood vessels will tend to dilate those blood vessels, will tend to lower blood pressure, and it tends to increase digestive activity. going to come back to that. So there are two different neurotransmitters used by postganglionic neurons, depending upon if they're sympathetic or parasympathetic. Those divisions are maintained except for visceral types of inputs to the skin and to sweat glands. So the main neurotransmitter released by postganglionic sympathetic neurons is norepinephrine. Norepinephrine. The neurotransmitter released by postganglionic parasympathetic neurons is acetylcholine. So we call these effects from parasympathetic neurons, we call those cholinergic. Cholinergic because the postganglionic neuron release acetylcholine. The postganglionic neurons of the sympathetic nervous system, because those are largely ones that release norepinephrine, we call their effects adrenergic. Adrenergic. And so the cholinergic effects will usually cause the pupils to constrict, the heart to slow down, the GI tract to get more active, and so on and so forth. Adrenergic effects usually involve constriction of blood vessels, visually speaking at least, increased sweating, increased heart rate, increased blood flow to muscles, and usually increased blood pressure. Those are adrenergic effects. And this table right here shows you the effects of the different branches of the autonomic nervous system on these various organs. Now, if you look at sympathetic effects, you'll usually see that things get more active with the exception of the GI tract. Sympathetic input to the GI tract is inhibitory. Now think about that. Why would that be the case if you need energy for emergency situations?
Doesn't it take energy to like break down the glucose metabolism?
Well, but it's emergencies. So you just want to use the energy you have.
Yeah.
And you don't have an infinite amount of blood. So you're diverting it to where you need it, like muscles. The GI tract, we'll deal with that later. So sympathetic input to the muscle tends to be inhibitory. So which side do you think gets activated when you're highly stressed? Sympathetic, yeah. You've got war exams on the same day. You've got biochemistry, physiology, and exercise phys and organic chemistry on the same day. That's going to activate the sympathetic nervous system. Now, people who get really stressed, they sometimes experience something called stress-induced constipation. Why do you think that might be the case? Because it's inhibiting the GI tract. Inhibiting the GI tract.
It says an inhibition of secretion and mucus glands in the lungs. Why?
Because for emergencies, you need more breath in the lungs. So you relax the bronchioles in the lungs so they can get more air. And then you reduce mucus, because mucus tends to narrow the openings in the lungs. That's why you use sympathomimetic drugs that activate the sympathetic nervous system for nasal congestion. And it prevents mucus production. See? Learn something every day, don't you?
You tried. So as we said, the cholinergic input is from the parasympathetic postganglionic nerves. And so that is essentially the signal that their targets will get. Now, the release of neurotransmitter by sympathetic nerves is different than what you see in skeletal muscles. So your autonomic nerve will pass through a smooth muscle like this, and there will be these swellings of the axon. These are called varicosities. Varicosities. The release of neurotransmitter exposes the smooth muscle to the neurotransmitter that's released. As the action potential goes down, the axon, each of these varicosities releases neurotransmitter. This type of release is called en passant. E-N-P-A-S-S-A-N-T. En passant. Anyone take French in high school?
Fish.
No, that's poisson. That's poisson. En passant means on the pass. On the pass. No, poisson is P-O-I-S-S-O-N. Poisson, yeah. Not poison, poisson. The Little Mermaid, les poissons, les poissons. How I love little fish, don't you?
So good.
So here is the varicosity. We have the release of the neurotransmitter. There are receptors here on the surface of the smooth muscle. Those receptors might be for acetylcholine. They will be usually muscarinic receptors, or they can be adrenergic receptors that will bind norepinephrine. Now, there's some exceptions to this rule in that sympathetic fibers that innervate blood vessels in skeletal muscles and sympathetic fibers to sweat glands. Those particular fibers are ones that use acetylcholine, even though they're sympathetic. That's the exception to the rule. All the others keep the rule. These are the ones that are exceptions. So the adrenal glands are part of the sympathetic nervous system too. The adrenal medulla only is innervated by sympathetic nerves, not by parasympathetic nerves. While the cortex of the adrenal gland releases thyroid hormones, the medulla releases epinephrine and norepinephrine into the bloodstream when stimulated by the sympathetic nervous system. So adrenergic stimulation can stimulate or can inhibit. What determines it? Determines on the receptor. Same neurotransmitter can give you different effects depending on the receptor. So there's two types of adrenergic receptors: alpha adrenergic receptors, beta adrenergic receptors. Those are the two types of adrenergic receptors. Then there's subtypes of alpha and beta receptors. There's alpha 1 and alpha 2 adrenergic receptors. And then beta 1, beta 2, there's also beta 3, but we won't talk about beta 3 receptors. And there's also an alpha 3 adrenergic, but we're not going to worry about those right now. And these are these different subtypes. And these particular receptors are found in different parts of your body. So, for example, alpha 1 receptors, when they're activated, tend to cause the release of internal stores of calcium. That causes smooth muscles to contract, to constrict. That causes constriction of blood vessels in the viscera and skin. That's what alpha 1 receptors tend to do. They cause vasoconstriction. Beta 1 adrenergic receptors are found in the heart zone. When they are activated by norepinephrine, they will cause heart muscle to contract more forcefully and faster. More forcefully and faster. Beta-2 adrenergic receptors. They're found in the bronchioles of the lung. They're also found in the smooth muscle that surrounds the uterus, in the myometer of the uterus. These actually cause those smooth muscles to relax, and you get bronchodilation. In the uterus, if you bind beta-2 adrenergic receptors, you cause that smooth muscle to relax. And so drugs that activate beta-2 receptors are given to prevent premature contractions. That can lead to premature labor. They're called tocolytic drugs, Tocolytic, tocolytics. And because they often also bind to beta-1 receptors and activate them, they tend to cause your heart rate to go way up. So that's one of the side effects of those drugs. They cause your heart to jump out of your chest. One of the intracellular signalers, second messengers, whose concentration either goes up or down in response to the binding of adrenergic receptors, is cyclic AMP. Cyclic AMP is made from ATP. The enzyme that makes cyclic AMP is called adenylate cyclase. Adenylate cyclase. So when you bind beta receptors, you stimulate production of cyclic AMP. When you bind to alpha-2 adrenergic receptors, you prevent the production of cyclic AMP. So these different receptors have a different intracellular machinery attached to them. That's responsible for the different response from the different neurotransmitters. So the same neurotransmitter will give you different responses. It depends on the receptor. And it depends on the intracellular machinery attached to that receptor. That's why you can get these disparate responses that are seen down there. So please do not fall into the trap of saying norepinephrine always causes vasoconstriction, always causes muscles to contract much more vigorously. Depends on the receptor. Different tissues will have different receptors on their cell surfaces. So as we said, alpha-1 receptors, they're all about calcium. They cause increases in intracellular calcium. That causes smooth muscle to constrict. Okay, this might get a little too personal, but maybe you've heard of a drug called Flonase. What's Flonase used for?
Oh, isn't it like?
No.
It's like a nasal spray.
Okay, I've got the trade name on. Flomax, sorry, Flomax. Flomax, yeah, Flonase is budesonide.
Flomax is uncommon, right?
Okay, doggone it, what is the name of
I spelled
the trade name of this drug? Oh, this is gonna bother me now. Okay, Flomax, that is the name of the drug. I was right, Flomax. Flomax. Flomax is taken by older people, especially older guys who have trouble going to doing number one. Now, why might those guys have trouble going number one? Because their prostate gets too big. Because their prostate gets too big, it shuts off their urethral sphincter. By giving drugs that block the alpha-1 receptor, that urethra now opens up and they can void their bladder. So there are groups of drugs that are usually given to older chaps who have something called BPH, benign prostatic hyperplasia. And that prevents them from being able to void their bladder because those receptors are found in the prostatic urethra.
Now, when you activate beta adrenergic receptors, you may get relaxation of smooth muscle, but you increase contraction of cardiomyocytes and you get an increase in the rate. So you get increased force of contraction, increased heart rate. And here is a table of where some of these are located. So in the eye, you have alpha 1 receptors. Those alpha 1 receptors will cause the radiofibers to contract. That dilates the eye. Guess what the ophthalmologist or optometrist puts in your eye for an eye exam? Guess what they put in your eye? Epinephrine. They put epinephrine in your eye, and that activates this receptor, and that causes those radiofibers to constrict and dilates the eye. Who'd have thunk? Who'd have thunk? Heart primarily has beta 1s, skin, visceral, usually alpha 1s, lungs, beta 2s, skeletal muscles, beta 2s, and that's what causes the skeletal muscle dilation. You get some constriction, but usually most of it, there are more beta 2s than there are alpha 1s, so usually in the muscles you get mostly constriction. Stomach and intestine, it's usually alpha 1s. Liver, it's usually beta 2s and alpha 1. That will cause the breakdown of glycogen and a release of glucose into the bloodstream. So herein lies the pharmacological principle behind how certain drugs work. Some drugs work as antagonists. They bind to receptors and they prevent the receptor from receiving any signal from any other ligand. So they block the receptor. An agonist is a molecule that binds a receptor and elicits a response. So there's an entire group of drugs called beta blockers. These are beta 1 and sometimes also beta 2 antagonists. So propranolol is a drug that's used for stage fright. It's used for migraine headaches. And it's also used for high blood pressure. This is a drug that blocks the beta 1 receptors in the heart, slows down the heart, lowers blood pressure. That's an example of an antagonist of the beta 1 receptor. Now, propranolol also will inhibit beta 2 receptors. So if you have asthma, it can actually make your asthma worse. What do? Then you try drugs that are more specific for the beta 1 receptor, like atenolol, or metoprolol, or bisoprolol, or something like that. This one is more specific, has a much higher affinity for the beta 1 receptor than it does for the beta 2 receptor. You can give this to an asthmatic. Asthmatics will inhale beta 2 agonists like albuterol or pyrbuterol or something like that, or levalbuterol. Those activate the beta 2 receptors in the lungs, that's why they're inhaled, and you dilate the lungs. Terbutaline is a beta 2 adrenergic receptor agonist. This is a tocolytic. This is given to prevent premature labor in people with premature contractions. My wife got some of this when Emily kicked the placenta, and the placenta started to detach a little bit, so she started to have contractions. She called for the on-call OB, and the on-call OB, Dr. Farhat, said, "Yeah, why don't you come in?" So she came in, they gave her terbutaline, and they infused it into her. She sat there and read, and her contractions all went away, and Emily was fine. And 12 weeks later, Emily was born, and now she's getting married this next summer.
Okay, that's misspelled. It should be phenylephrine. Phenylephrine. I'm sorry, phenylephrine. Phenylephrine is used in a lot of nasal sprays. Anyone ever take Sudafed? That's pseudoephedrine. Pseudoephedrine, a chemical cousin of phenylephrine. These are used to prevent mucus secretion by the nasal mucosa when you have a cold. Clonidine, that's an agonist for the alpha-2 adrenergic receptors. These are specific to the central nervous system. They're regulators and prevent neurons from releasing norepinephrine. So this is used to lower blood pressure. There are better drugs now, not quite so much. This drug can make you really drowsy. It's also used for ADHD because it tends to calm down neural processes in the prefrontal cortex. So acetylcholine always excites rule. There's an exception to it because it depends on the receptor. The vagus nerve will slow the heart rate. And the reason for this has to do with the receptors. So if you are binding a nicotinic receptor, that's excitatory. Muscarinic receptors, however, come in different shapes and sizes. There are M1, M2, M3, M4, and M5 receptors. The receptors that you find in the lung tend to be ones that excite. Those tend to be M2 receptors. The M3 receptors you find in the heart, they're inhibitory. Again, depends on which receptor and what its targets are. You can see in this case, it's a potassium channel that will hyperpolarize the cell. That's inhibitory. So acetylcholine doesn't always activate. If it finds a nicotinic receptor, it sure does. But it depends on the type of muscarinic receptor. There's different types of muscarinic receptors. So this table, table 9.6, shows you responses essentially. Oh, I got those mixed. Sorry, M2s are in the heart. Sorry, M2s. M2s are in the heart and those hyperpolarize. Your M3s, you find those in smooth muscle, glands, things like that. Autonomic ganglia, pre-ganglionic nerves use nicotinic receptors, so they skeletal muscle. But these others are going to be inhibitory, like the M2s that you find in the heart and also other places as well. So this shows you essentially the receptors and the responses you get when you activate them. So these are tables you should spend some time with, and you should be pretty familiar with the location and function of many of these receptors. There is a logic to it, and that logic hopefully will become more apparent as you look at it. So the bladder wall relaxes. The myometrium relaxes. Walls of the gastrointestinal tract relaxes. Basically, wherever you see beta 2s and smooth muscle, they will cause relaxation. Alpha 1s usually, wherever you see them in smooth muscle, they're going to cause constriction. Whereas with glands, they're going to cause inhibition, usually. Beta 1s, on the average, are going to be activational, but beta 1s aren't found in many other places outside the heart and the kidney. Alpha 1s, if they're involved, usually with smooth muscle, they're going to cause constriction. But with glands, again, it's going to depend. They're usually going to prevent glands from releasing things. Parasympathetic, boy, it depends on the type of muscarinic receptor. So with some, they're going to be inhibitory. With others, they're going to be more activational.
Now, there are organs with dual innervation. Dual innervation, they're innervated by both branches of the sympathetic and parasympathetic branches of the autonomic nervous system. The interaction between these two branches takes a couple of shapes. First, we have antagonism, and this is probably the most common. So in the heart, sympathetic input speeds it up. Parasympathetic input slows it down. They antagonize each other. Full stop. Full stop. Atropine. Ever heard of atropine? Somebody's heart stops, you give them atropine. Atropine inhibits acetylcholine effects in the heart, thus restarting it. Someone has a heart attack and the heart stops, you give them epinephrine. That kickstarts the heart because of the sympathetic input into the heart. Eye muscle activity, same song, second verse, antagonism. Whereas your sympathetic input will tend to cause dilation, and parasympathetic input will tend to cause constriction. That is due to the fact that you have innervation of two different types of muscles. The radial muscles are innervated by the sympathetic nerves. The constrictors, the sphincter, circular sphincters, those are innervated by the parasympathetic nerves. They antagonize each other. Okay, I've got one more minute and I've got 2 slides left. Input can, however, be complementary or even cooperative. So for example, salivary glands. Salivary glands, when you have dual input, parasympathetic input gives you more watery saliva. Whereas sympathetic input gives you release that's got more stuff in it. So in this case, you have kind of a complementary activity. One causes more secretion, the other actually puts more goop in it. So you get more enzyme, more mucus, so on and so forth. That dual input actually helps the salivary glands in cases like that. Similarly, we have complementary activity in the GI tract. So increased blood flow to the salivary glands causes a thicker, more viscous saliva. And however, you get constriction of blood vessels throughout the digestive tract. Where you also get complementary activities with the sexual response. And the sexual response, you actually have complementary activity of sympathetic and parasympathetic inputs to the reproductive organs. So I leave you essentially with this table that shows you different inputs in the vagus, and that's table 9A. Please take a look at that. That is the sympathetic nervous system. Wednesday, we will start special senses. You've already done the lab on this. And we won't have class on Friday, and there's no lab on Thursday. All right. Any questions before we break for the day? Hey, Savannah, heal thyself, get plenty of sleep, drink plenty of fluids, and we'll see you when you get well, which I hope is soon. Okay? Everybody wave to Savannah. They're all waving, Savannah. They miss you, so get well.